as a speaker. She is vitreoretinal surgeon with extensive expertise in the diagnosis and management of complex retinal disorders. Dr. Paliwal has completed her MBBS from Government Medical College, Nagpur, and later pursued DNB in ophthalmology. She further advanced her training by completing a vitreoretinal fellowship at Narayan Netralaya, Bangalore, where she received specialized training in both medical and surgical retina. Her clinical practice includes management of wide range of retinal diseases such as diabetic retinopathy, retinal detachment, age-related macular degeneration, vascular occlusions, and various macular pathologies. She is also experienced in evaluation and management of retinopathy of prematurity (ROP) and is proficient in performing laser therapies, intravitreal pharmacotherapies, and complex intravitreal surgeries. In addition to her clinical work, Dr. Paliwal has contributed to ophthalmic research with publications in several peer-reviewed journals and is regularly invited as a speaker at CMEs and national and international ophthalmology conferences. So on this, I would like to invite Dr. Paliwal ma'am for giving a talk on diabetic macular edema from understanding it to treatment. Ma'am, you can initiate the presentation, please.
Yeah. Am I audible?
Yeah,
Hello, good
ma'am.
evening. Yeah.
Yeah,
So, good evening, everyone. I would like to thank Bear for giving me this opportunity, and I would like to directly start with my presentation on diabetic macular edema from understanding to treatment. So, these are my disclaimers. So, we know that the global burden of diabetes is rising and will continue to rise in the coming decades, and India being the diabetic capital of the world. So, what is DME? We all know that DME occurs when blood vessels in the retina leak fluid and proteins into the macula, causing the macula to swell, which in turn affects the visual function. So, any of the retinal vascular disorders, VEGF is an important mediator of inflammation, and also in DME, VEGF-A plays a key role in pathophysiology. It increases the vascular permeability and disrupts the blood retinal barrier in DME. DME can affect people with both type 1 as well as type 2 diabetes. Vision loss in patients with DME can have life changing consequences like difficulties in performing near vision tasks, difficulty driving, difficulty in reading, increased risk of depression compared with the normal vision because of the ongoing deterioration of vision, as well as the treatment burden of multiple intravitreal injections, difficulty in perceiving colors, and increased mortality risk compared with the normal vision. So DME can occur in individuals at any stage of diabetic retinopathy, whether it is mild diabetic retinopathy, moderate or severe, or even in advanced PDR cases. And badly controlled diabetes and untreated DME can lead to severe visual impairment and blindness. So this is what a normal macula looks like, and this is what happens when there is swelling on the inner retinal layers in patients with DME. And this is what we see clinically. When you see a patient with DME, we see these red dots, which represents microaneurysm, and this yellowish lesions, which are hard exudates, which are arranged on the macula in circinate pattern, and then we call it as DME. So coming on to the treatment of DME, which has evolved over time. Currently, anti-VEGF is considered as the gold standard treatment for the visual impairment due to DME. It basically started with laser photocoagulation by ETDRS study in 1985. At that time, laser was considered to be the gold standard, and still pan-retinal photocoagulation is considered as the gold standard for treating proliferative diabetic retinopathy. But yes, anti-VEGF is now considered as the gold standard for treating DME. So then came VEGF agents. In anti-VEGF agents first started with ranibizumab in 2011, and then fluocinolone acetinoid, that is a steroid implant, in 2012, even though not available in India. Then another drug, that is dexamethasone, which is also a useful drug in patients in which anti-VEGF agents are contraindicated. Then we had eflibercept in 2014, faricimab in 2022, and now we are coming on to eflibercept 8 mg, which is first approved in 2023. So, what are the key mechanisms behind pathogenesis of DME? So, as I said, VEGF is a key mediator of inflammation in any of the retinal vascular disorders, and also in DME, VEGF A and placental growth factor act via the various VEGF receptors to promote vascular leakage, edema, inflammation, and neovascularizations in patients with diabetic retinopathy. So, this is all what we know. It basically, what happens in patients with diabetic maculopathy is an increase in the glucose level. There is excess accumulation of glucose, which leads to the activation of other pathways like protein kinase pathway, sorbitol pathway, which and leads to increase in the inflammatory mediators like VEGF and placental growth factors, leading to impaired retinal blood flow, hypoxia, which leads to chronic inflammation and RP cell damage, endothelial cell breakdown, parasite loss, opening of tight junctions, breakdown of blood retinal barriers, leading to vessel leakage and edema, and then ultimately leading to the formation of new vessels, that is neovascularization. So, what is the difference between the other molecules of the anti-VEGF agents which are available in the aflibercept? So, aflibercept is the only globally available anti-VEGF agents that target multiple mediators of retinal disease, like brolucizumab and ranibizumab only target VEGF-A, but yes, aflibercept target all three mediators. So, to summarize, VEGF-A and VEGF-B, VEGF-A, B, and placental growth factor are key drivers behind the pathogenesis of DMA, and aflibercept is the only globally available anti-VEGF agent that targets multiple mediators of retinal diseases. And there is enough evidence from randomized controlled trials, real world evidence, network meta analysis, international guidelines, and even our own experience to support that yes, anti VEGF is the choice of patients in diabetic macular edema. So, what about the trials? Trials like Vivid and Vista trials in patients of DME with aflibercept, and also Protocol T, which said that clinically meaningful vision gains were achieved in patients who received early intensive treatment with aflibercept. Vision gains were observed as early as with the first aflibercept injection, and patient received greater than 8 injections through year 1 and maintained vision gains achieved during the initial loading phase. And across all the three studies, patient treated with aflibercept gained on an average greater than 10 liters. And at the week 52 primary endpoints, aflibercept demonstrated superiority to laser in the Vivid and Vista trials. Yes, delaying aflibercept leading treatment leads to poor visual outcomes. From the protocol T, it is very well said that yes, when amongst all the three drugs, bevacizumab, aflibercept, ranibizumab, aflibercept has superior efficacy, especially in patients with poor vision. Also, the meta-analysis and expert international guidelines, like one of the meta-analysis say that yes, at year 1 all efficacy outcomes significantly favored aflibercept over ranibizumab and bevacizumab. Patients were approximately 30% more likely to gain greater than 3 lines with aflibercept than with ranibizumab or bevacizumab. And yes, anti-VEGF agents did not differ regarding the systemic side effects in these patients. Various international guidelines also recommend aflibercept as the drug of choice. Like we had our Euretina guidelines, which say that what I said earlier is the drug of choice in DME eyes with a baseline visual acuity of 20 by 40 or worse, as it shows superiority to bevacizumab over 2 years and over ranibizumab in the first year of treatment. Similarly, the other recommended guidelines also suggest the superiority and efficacy of aflibercept over the other available anti-VEGF agents. In the clinical practice, this drug has also been proved, like data from Moorfields Eye Hospitals also registered the efficacy of aflibercept in patients with clinical practice. And also, data like given by Hirano et al. Also says that yes, in DME patients, majority of patients with DME achieve 16-week treatment intervals with an individualized treatment and treat and extend regimen with aflibercept initiated in year 1. So, to summarize, aflibercept can achieve meaningful vision gains in patients with DME as demonstrated by the randomized controlled trials. Meta-analysis and international guidelines and recommendations suggest aflibercept should be the drug of choice when treating patients with baseline visual acuity of less than 20 by 40 or worse. Real world evidence also highlights the effectiveness of aflibercept in the clinic, where patients regularly present to us with poor vision and delayed outcomes. Patients with visual impairment due to DME, particularly those with baseline less than 20 by 40 or worse, can achieve meaningful vision gains with aflibercept compared with other anti-VEGF agents in the real world clinical practice. Thank you.
Yeah. Thank you, Sonal ma'am, for the wonderful presentation. Sushil ji, Dr. Mihir has joined.
Yeah, I'll give me just a couple of minutes. I'm just checking with him.
Yeah.
Yeah, I spoke to him, Dr. Mihir. He's joining in a couple of minutes.
Okay. Yeah, Mihir sir, we can see you.
Yeah,
Sir, you are
can
mute.
you hear me? Can you hear me?
Yeah, we can hear you. So I'll just
Yeah.
give a introduction. So I would like to invite Dr. Mihir Trivedi. He's a
Right.
VR surgeon based in Mumbai with 14 years of extensive experience in this field. Dr. Mihir has completed his MBBS from KIM Hospital in 2012, MS Ophthalmology from Sion Hospital in 2016, and DNB in ophthalmology and from National Board of Examination in 2016. He is also a member of VRSI, AIOS, Bombay Ophthalmologists Associations, and Maharashtra Ophthalmological Society, MOS. So I would like to invite Dr. Mihir with his presentation. So you can share your presentation, please.
Yeah, I'm trying to share the screen. 1 minute.
So Dr. Mihir will be giving a talk on evolving role of aflibercept in PCV. We'll be talking about APVRS insights and comparison with the anti-VEGF agents.
Can you see my screen? No,
Sir, it is not yet shared.
just 1 second. There is some problem. Now?
Yeah, now it is sharing. Yeah, now it is sharing. Yeah, we can see it. If you can like slideshow of this.
Yeah. Just 1 second. Actually, I'm on a new laptop, so
No issues, sir. Please take your time.
hello.
Tech
Just
support, can you please help Dr. Mihir how we can
Yes, sir.
slideshow this? Yeah, please.
yeah. Can you see now?
Yes,
Yes,
sir.
sir. It is not full screen. Yeah, please. You can start the presentation, sir.
Yeah, it is full screen, right? So I just 1 second. So I'll be talking on the evolving role of aflibercept in PCV, the APVRS insights and comparisons with other anti-VEGF agents. So the whole point of this talk is that in many patients with PCV, aflibercept monotherapy achieves clinically meaningful visual outcomes in patients with suspected types of NM. Neovascular AMD such as PCV. So basically, the APVRS guidelines of 2025 state that whenever a diagnosis of PCV is made, of course there are many diagnostic criteria. I'll not go into that detail, but whenever a diagnosis of PCV is made, we can either go for an anti-VEGF monotherapy or a combination with PDT. But unfortunately, due to non-availability of PDT at many centers in our country, we do usually offer anti-VEGF monotherapy. So in anti-VEGF monotherapy, we again go to, we see either there is complete regression or stabilized SRF. If there is, then we gradually we gradually extend the intervals with the treat and extend regimen. If there is persistent or recurrent disease activity, then we shorten the interval with treat and extend regimen. Either we go for a combination or altogether switch the anti-VEGF agent itself. So APVRS guidelines state that monotherapy monotherapy with anti-VEGF treatment is effective in many cases of PCV and can be used initially as monotherapy. To date, there are no data exploring whether faricimab or brolucizumab monotherapy are non-inferior to combination therapy in patients with PCV. So this is a short summary of the of molecular properties of the currently available agents, anti-VEGF agents. So as we can see that the KD is basically inversely proportional to binding affinity. So KD of aflibercept is is the lowest amongst all available anti-VEGFs. So the binding affinity is the highest for aflibercept, and also the point to note is the number of targets. So number of targets in aflibercept is 4 as compared to the next maximum, which is faricimab, which is 2. So this was another, in 2016, there were two main trials, which were View 2 and Planet. These are pivotal aflibercept trials demonstrating that PCV can be treated similar to NAMD. So in View 2, patients with PCV and patients with NAMD achieve similar vision gains with aflibercept monotherapy. And in the Planet study, PDT can be reserved as rescue therapy for suitable patients. So this is in short. I'll not go into the complete details of this study, but but the Planet study, this was basically, we wanted to see if there is it was a prospective sham control study assessing the efficacy of aflibercept monotherapy compared with aflibercept plus active PDT for the treatments of patients with PCV. So at the end, we found that monotherapy was almost giving better results than a combined aflibercept plus PDT therapy. In Planet study, vision gains were maintained using aflibercept monotherapy with optional treat and extend dosing in year 2. Patients with extended intervals in year 2 maintained vision gains with a reduced treatment burden. So as we can see here, that at the end of year 2, aflibercept monotherapy, the mean change of the mean BCVA was plus 11.1 letters gain, as compared to the combination where it was plus 11 letters. So this was another study, Alter study, where vision gains were maintained with aflibercept 2 mg treat and extend regimen in patients with or without PCV. So similar proportions of patients with or without PCV were extended to intervals of Q12 by week 96 with aflibercept 2 mg treat and extend. So basically, at a 3 or a 12 weekly interval injection at week 96 was giving similar results in PCV patients or NAMD patients as well. So this was another study. Maruko et al. reported similar outcomes with aflibercept 2 mg treat and extend through 2 years, regardless of the NAMD subtype. So real-world patients with PCV can achieve vision gains comparable to those in RCTs. So at here we can see that in the various trials at 12-week interval, 59.5% patients have a baseline BCV gain of 8 letters, and in the other trial by Morisen and Hosokawa, the 16-week interval regimen gave a 47.3 in 47.3% patients. So the vision gain was 65.5. This thing, there was a plus 9 letter improvement. So these are the various studies where we see that complete polyp regression. This is one of the important clinical findings with aflibercept monotherapy. In these many studies, we have seen that there is a complete polyp regression in these many percentage of patients in the various studies, mainly the Japanese case series. So this is one study which I would like to highlight, Planet and Salvin. This is a comparison study. So Planet, as we have already discussed, so there was non-inferiority of aflibercept monotherapy. Actually, aflibercept monotherapy was better than aflibercept and rescue PDT, and there was absence of polyps and absence of leaking polyps at week 52. This was comparison study with PDT. Salvin was a open label single arm study where it was a faricimab study where they assessed the polyp regression. Only 77% had confirmed diagnosis of PCV by CRC. So aflibercept versus faricimab. Here we can see that it's a study by Hara et al. The BCVA significantly improved only in aflibercept group at 3 months after the first treatment, but no significant improvement was observed in the faricimab group. Even the exudative changes and the resolution of polypoidal lesions was better in aflibercept compared to the faricimab group. So conclusions, head-to-head comparison of a real-world study in treatment-naive NMD patients, all were Japanese population. Both aflibercept and faricimab treatment are effective in reducing the exudation and retinal thickness. However, aflibercept was more likely to eliminate exudative changes and improve visual acuity after loading doses. Both IVA, aflibercept and faricimab are effective in reducing exudation and retinal thickness. However, aflibercept was more likely to eliminate exudative changes and improve visual acuity in the short term. So aflibercept 2 mg efficacy and safety profile has been established across RCTs and is supported by over a decade of real-world PCV, PCV monitoring. Low rate of adverse effects. Rate of IOI is just 1 in 10,000 vials which are sold till date. Rate of endophthalmitis is just 0.6 in 10,000 units sold. And ADA data suggests no association with immunogenic response. Thank you.
Yeah, thank you, Dr. Mihir, for the wonderful talk. Sir, we have a question if you and ma'am can answer. The question is like any experience with aflibercept biosimilar in PCV or any other indication? Is it safe to use?
Can I take it or?
Yeah, please, sir. Please, sir. We can have your opinion as well as ma'am opinions.
Yeah. So basically, aflibercept biosimilar has been recently launched. I think you're talking about aflibercept biosimilar, right?
Yeah, sir. Yes, sir.
So aflibercept biosimilar. The one which is being used as Zaltrap you're talking about, or the one which has been launched by Zydus?
Recently launched by Zydus, yeah.
I don't have any clinical experience for that. I have actually asked a couple of my retina colleagues. We haven't used it as of now, but I'm actually looking forward to use it to see if what is the efficacy, we are just scared right now to be the first users. So I don't have any practical experience, but we are looking forward to use this. As far as Zaltrap, if you're asking, Zaltrap is a different thing. So I'm
okay,
not
yes, sir. Yes.
Zaltrap.
Yes, sir. We are not. The question is not about Zaltrap. Yeah. Sonal ma'am, can we have your feedback on this? If you can throw some light.
I think same, Pratik. I haven't used aflibercept biosimilar in my practice as such, and yes, but I'm waiting for the Zydus one. Let's see when it comes. I think last week he came and meet me, so let's see how it works. Would be
Okay.
interesting to find out that, but till now I don't have any experience in any of the aflibercept biosimilars as such.
Okay, ma'am. Okay. Thank you for feedback. Yeah. We don't have any other questions. Yeah, we are good to close. I would like once again thank you all for sparing your valuable time for this scientific meeting. And once again, a big thanks to Sonal ma'am and as well as Dr. Mihir for giving us such a wonderful talk. So thank you and good day.
Thank you, Pratik. Thank you so much. Thank you.
Thank you
Yeah.
very much. Thank you, everyone.
Good day, everyone. Good day.
Thank you,
Bye.
ma'am.
Bye.